Thank you for having me, Carol. Thank you for inviting me. Yes, I have sutured, I don't even know how many friends and family, and injected, and all over the body. So plastics is much more, less cerebral than other ophthalmology. Suturing and tissue are very similar everywhere. So thank you for having me. I thought a fun topic would be some can't miss oculoplastics emergencies, some masquerades, some sneaky players in oculoplastics, and then just a brief foray into imaging. I have no disclosures. So most oculoplastics emergencies are related to the structure of the orbit. So plastics, like surgery or more general surgery, it's very structural, mechanical sort of issue, and the orbit being an enclosed bony cavity is the result of most of our emergencies in oculoplastics, although less cute than this one. So all of us have memorized these numbers over the course of our training, the dimensions of the orbit, the volume the orbit can hold, the standard depth and width of the orbit. And of course, we've all also memorized this figure here, depicting the restrictive soft tissue structures of the eyelid. So the orbital septum being that taut structure that separates the preseptal and postseptal orbit, and pathology that is posterior to that septum is caught within a tight enclosed space and results in compartment syndrome. So here we have some classic examples of compartment syndrome. What compartment syndrome is, it's a pressure issue. It's when the intraorbital pressure exceeds the vascular perfusion pressure of the ophthalmic artery, and that's how it compromises vision. And if it's not corrected urgently, you can have irreversible vascular compromise and vision loss. On the top figure, we have a trauma and retrobulbar hemorrhage, and in the bottom figure we have a classic example of thyroid eye disease, which is a more gradual elevation of intraorbital pressure. So the etiologies are manyfold. As you know, they can be acute, related to trauma or sudden bleed, or infection with an abscess or a gas. They can be more chronic, for example, due to slowly growing vascular lesions, due to tumors, due to enlarging extraocular muscles and fat in thyroid eye disease. Or acute on chronic, for example, a tumor with a sudden hemorrhage that results in an acute increase in intraorbital pressure, or venous lymphatic malformation, for example, with an acute engorgement. Again, we all know our infectious processes of the periocular and orbital structures, preseptal cellulitis being anterior to the septum, and less vision threatening. And then of course there's a intraorbital abscess, most classically a subperiosteal abscess, because orbital infections most often come from the surrounding sinuses and cause that dome-shaped abscess. Under the periosteum. Of course, the most feared complication of orbital cellulitis would be posterior extension into the cavernous sinus and then potentially even intracranially. So that last picture is a little deceptive, because usually if you have cavernous sinus inflammation or infection, it also involves the orbit. It's probably not in isolation. So here we have an example of a very classic infection right over the lacrimal sac, a dacryocystitis, which, although can be very painful and bad-looking, is actually preseptal. And typically, unless it's very severe, managed as an outpatient, as most preseptal cellulitis is. If it has come really to a head, you might do an abscess drainage, maybe in the office, and then send home on oral antibiotics with the plan for a DCR down the line once the inflammation has calmed down.
Well, I know, but that means apply.
On the other hand, we have an example of an orbital cellulitis concerning orbital signs.
Everything slowly came
back. In addition to the significant lid edema, the eye looks a little proptotic. There's restriction in motility. This patient probably also has possibly some vision change and maybe even pupil changes to suggest an orbital
Yeah,
process.
that sounds reasonable.
So those are some of the more classic
if you
ones,
think
but
so.
some particularly insidious players that can look sort of innocuous initially,
otherwise,
or
you're put
less
for that
severe
long,
initially,
everything
but
else,
then
you're-
progress very
you're
rapidly. One is
cross-species, and this-
fungus. So here's a
having injury.
patient
Just,
who has immunocompromise. He's a post-liver transplant. He's on immunomodulatory medications, and he's got
I know.
this scab of his skin, very subtle lid edema, nothing too severe. And on his imaging, you can see he's got.
Cross country season, so you have to learn.
point at it here.
Yeah, so we'll. But
There's
you're-
just a little bit of
understand there are
inflammation,
high
and
risk
on the other
of the
cuts you can
injection?
see just a
Right.
little bit of fat stranding in the inferior orbit.
Okay.
And he's being treated by ENT. He's
All right,
undergone a sinus debridement, and is admitted to the hospital for IV antifungals. This, in addition to all of that, although his orbital findings are very subtle, we actually did daily voriconazole injections into the orbit every day for I don't know, maybe like 2 weeks or so, because these are the type of infections that get very bad very, very quickly. In an immunocompromised person, just a little bit of the imaging is usually a little delayed from the what's going on biologically, and if it isn't treated very aggressively, it can progress very quickly in the orbit. So a patient with immunocompromised patient with kind of like subtle exam findings and subtle imaging findings should be treated much more aggressively than you might otherwise think. The findings will not be as dramatic as they would be for a bacterial infection. He did very well ultimately with
yeah, I got one more to go though. So.
with resolution
I could
of all
fall
his
on the next.
inflammatory signs, but if not treated aggressively, often it goes in a very different direction. Do you mind advancing? Should I just? Did I do something? I can't go forwards or backwards. Yeah. Well, I can keep talking while we wait for the pictures. And then we all know about the landmark study by Gerald Harris looking at orbital cellulitis in children, showing that orbital cellulitis in older children tends to be much more aggressive. The reason for that being orbital cellulitis in younger children, although it looks very bad, is usually a single organism, whereas in older children it tends to be these polymicrobial, very aggressive type cellulitises. And they need to be treated aggressively and probably with surgical management sooner than you would in the younger group. So if you have like a 9-year-old with an orbital cellulitis, you probably are going to give them maybe 24 hours on antibiotics before, if they're not showing some major improvement, you start considering taking them to the operating room for abscess drainage. Orbital cellulitis in children, in older children as well, is where you might see something like a more serious complication, such as Pott's puffy tumor, which is where you have frontal sinus infection that can spread to a subperiosteal superorbital abscess or scalp abscess, and it's those children get those children or adults get very sick very fast. So that's another instance where if they have that frontal sinus infection and superorbital signs, that's an indication this is not your standard cellulitis. You need to be considering surgical intervention much sooner on this child. And then gas-forming bacteria, so here's an example of a Pott's puffy tumor, a frontal sinus infection with a superior subperiosteal abscess. Gas-forming bacteria is just something that we've seen more in our institution over the course of the past year. Gas-forming bacteria, necrotizing fasciitis, those are things that we don't see much around the periocular region typically, or certainly not in the orbit. But just in the past year in our institution, we've seen like 3 in a row with necrotizing fasciitis of the orbit. It seems like there's rising rates of streptococcal infections in the community in general. This might be something we're just seeing more of recently. And obviously, if you see any signs of your classic necrotizing fasciitis symptoms in the periocular orbital region, you treat it like necrotizing fasciitis with aggressive debridement and possible repeated debridements until you have viable tissue. And just like elsewhere, the symptoms would be the same. Gas in the orbit or in the subcutaneous tissues on imaging, aggressive, coarse, evidence of necrosis, so duskiness, purplish or bluish hue, obvious sloughing of tissue, that kind of thing. Oh no, not again. Oh yeah, that's a great idea. That is a concern, but it's pretty unlikely. I suppose if typically you drain it, you just need to make a very small puncture and it comes out nicely. I suppose if I saw like a large tract, I might put a suture in to decrease the likelihood of that. But typically I haven't really seen a fistula formation. I don't routinely drain it unless it is a pustulant, like, dilated sac that clearly looks like it might just drain through the skin on its own imminently, which is the minority. Most of the time, if it's just a little bit boggy and tender, I put them on oral antibiotics and it comes down on its own, and then we fix it with DCR. And if they did develop a fistula formation, you could always address it at the time of DCR. You're gonna take part of the sac anyway, and then you could address the skin fistula at that time if needed. Okay. Oh. Okay. So this is a young child with a chronic venolymphatic malformation that abruptly bled in the context of him having a viral illness. So venolymphatic malformations or other vascular malformations are another cause of acute orbital compartment syndrome. Here's another young lady with a chronic venolymphatic malformation causing proptosis, compromised vision, and disfigurement. And you can see how these are really involved. You might see a little mulberry patch on the conjunctiva sometimes, but it's the tip of the iceberg. They usually expand very far posteriorly into the orbit and are very difficult to treat surgically because of how adjacent they are to orbital structures and to the orbital vasculature. The treatment that this patient underwent was embolization with interventional radiology, and you can see she had significant improvement in her proptosis and in her eye appearance. They do tend to reform over time. The vessels just kind of find other connections and reform and might require multiple treatments over time. In the acute phase with that child, for example, you might want to drain a pocket of heme if there's an acute worsening in vision. Otherwise, you manage it symptomatically if the vision has not been affected with lubrication. Another bad player that can cause acute orbital compartment syndrome, carotid cavernous fistula. This is a patient who presented with eye redness and pain, and her initial scan was not noted to be particularly remarkable until we noticed that she had this kind of abnormal appearance to her cavernous sinus. So the scan was re-examined, and repeat imaging with MRI and MRV was performed, and this dilated superior ophthalmic vein was noted, and the enlargement of the cavernous sinus was noted, pointing towards a carotid cavernous fistula. And again, that was also managed with interventional radiology performing embolization. The other structural feature of the orbit is the narrow passageways. So that is another reason why we encounter acute emergencies in the orbit. So again, we've all looked at this type of image a million times, memorizing where do different things come out of, what comes with what. And the reason it's relevant is because it affects the exam, it affects the pathology. So this is a picture I show to the residents all the time to help them think about their orbital apex and their other orbital fissures, and how the physical exam is actually, this is an example of where in the world of MRIs and all the technology that we rely on, where a physical exam is immensely helpful, especially for subtle things like fungus, where you're following them and you're trying to tell, is this getting worse? Is it responding to treatment? Your scan is gonna lag, and your physical exam might actually be the thing that clues you into, oh, this is spreading to a different place. So I always tell them to kind of think about it like this, like if you're going from the cavernous sinus to the orbital fissure to the orbital apex, what are your cranial nerves that are involved? And you can see these are shared, but if you see V2 involvement, you know your cavernous sinus is involved, but you would not expect your optic nerve to be involved with cavernous sinus pathology. If you see your optic nerve involved, you know that something has gone to the orbital apex. So at the bedside, we are checking these things, and it might be the first clue that some subtle process is moving between these narrow passageways. So retrobulbar hemorrhage, probably at some point during training, or many points during training, every one of us has encountered this and had to deal with it emergently. So the findings would be the appropriate history, of course, and then the exam findings of elevated intraocular pressure, restricted movements, maybe an afferent pupillary defect. You may or may not be getting imaging. This is an emergent condition, so often it's a clinical diagnosis and you're not taking the time for imaging. As I often tell the residents, this is not really an ophthalmology procedure, it's an emergency room procedure. They're not really, it's an emergency. They're not really supposed to be like, oh, boop, 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 let's page the opto resident and wait for them to get over here. So most of my friends who are emergency room doctors have done much more of these emergently than I did. I do a lot of these as a part of a procedure, like a planned eyelid or orbit procedure, but I actually haven't done many of these emergently because it's not really an ophthalmology procedure, but we should all know how to do it, of course. And during training, our residents get to do so many of these as part of the first step to so many of our procedures. So I always tell them that when it comes to doing it emergently, it'll feel like a piece of cake. But to make a small cut in the lateral canthus, and just a few millimeters. It doesn't have you don't get more release for having made a large disfiguring incision in the lateral eyelid. The lateral canthal tendon is right there, so just a 3 millimeter incision is really all you need. Cut that canthus, strum for the lateral canthal tendon, and this is not really working, but as you can see in the picture, strum for the lateral canthal tendon, release the inferior tendon. If you get a lot of pressure release, but it still feels very taut, what should you do? Cut the superior. Let's say that you get a lot of release, but there's still a lot of tension. What could you do? You could cut down the conj, you could go into the inferior fornix and just slide one blade of your scissor in there, and kind of like you would do if you're doing a retractor reinsertion, open up that conjunctiva. Now you've opened up the whole septum. And so more heme or whatever is trapped should come out from there. And you're in the fornix, so that conj will heal okay. It's not right by the limbus or anything. So we all know our good friend thyroid eye disease. This is a patient with a male patient, and as we know, male patients tend to have more aggressive disease. He's a non-smoker, actually, who presents with the classic pressure-like pain, pain with eye movements, some lid retraction, proptosis, some resistance to retropulsion. I encourage all trainees to learn to palpate globes, and that way you get to feel what does a normal orbit feel like. It's a very valuable physical exam skill. When you see people with orbital conditions and you feel their orbits, and then you feel them after that orbital condition has resolved, that feel is very different, and it correlates to what they're experiencing. If they're experiencing pressure around the eyes, you can feel it. It feels taut. So his scan showed the classic enlarged extraocular muscles and proptosis of thyroid eye disease. And you can see, even though maybe his exam is not as dramatic as you might see in others, as is typical, men tend to have more aggressive disease, he actually is already starting to have some visual field deficits as a result of his thyroid eye disease. He underwent treatment with teprotumumab, and you can see resolution of his lid retraction. He's less proptotic. You can see even he had become so proptotic that he developed and he had lid edema, that he had trichiasis from his epicanthal folds, which normally are not congested and folded up and scratching his eye, but he had trichiasis as a result of that, so he had actually had to have a epiblepharon repair, which usually we're doing in kids, but we had to do it in him just to relieve his cornea. But after treatment, his edema has resolved significantly. That's a whole conversation of its own, thyroid eye disease and what is the best management. It's an evolving discovery. We know that we have one immunomodulator, at least, teprotumumab. There are others that are going through studies, and there's probably a whole influx of them that are going to come in. And certainly we know that the immunomodulators work for certain patients in quieting disease. There's emerging data about the recurrence rate of them afterwards. We're finding some patients stay quiet for a long time. There's a small subset of patients where they tend to recur after a while. So we're still learning who are the best patients to treat initially with immunomodulators versus with our old traditional treatments, such as radiation, or in which cases would perhaps decompression be appropriate for, more, of course, for an acute case where if you have like acute compressive optic neuropathy and you need to relieve the orbital apex. But is there a subset of patients with chronic congestion from thyroid eye disease where decompression would be appropriate over immunomodulator? A lot of nuances there, a whole conversation that I'm happy to have with anyone who's interested. So let's talk a little bit about masquerades in oculoplastics and some pearls of just the physical exam that can help you to catch the masqueraders. So this is a lady, she's 50 years old, very healthy, who presents with this bump on the edge of her eyelid, kind of looking like, related to the meibomian gland orifices, not painful, and you can see closer up. It's very isolated. It's just in that one focal area. So what might you be thinking? Okay. Well, I was thinking chalazion. But obviously, I don't take pictures of all my chalazions. So obviously, I was also thinking something else. But I told her, I think this is just a funky-looking chalazion. But I send off all my specimens anyway, so I'm like, we're definitely gonna send this one off. And the reason I took a picture of what I thought was this probably still a chalazion is because of the history. So this had been going on for 6 months. A chalazion should not look this angry after 6 months. You can see, I don't know if you can see with the glare, on that posterior surface, you can see those blood vessels. It's just a little weird. Like after 6 months, chalazions become quiet. They just look like a little nodule that is flesh-colored and just kind of hanging around and kind of maybe annoying to the patient because it's there, but it shouldn't still have these angry blood vessel or, big blood vessels coming to it. So what I was thinking is, this is probably just a chalazion, but maybe a weird sebaceous cell because it came from this posterior lid. So for our residents in particular, when I'm thinking about what is this bump, because I see bumps all day, right? So that's where I think Dr. Paul Breyer spoke to you a few days ago. I was like his lectures because I take it back to, well, what are the cell types that live here? If this was on the skin side, I'd be thinking, okay, skin cells live here. So if this is something bad, it's going to be something of skin origin, like a basal cell or a squamous cell, or maybe something weird like a Merkel cell. The skin cells, or maybe a very rare sweat gland tumor or something like that. This was on the posterior lid, so I'm thinking what cells live on the posterior lid. So you have your conjunctiva, your meibomian gland orifices. So I'm thinking more something from like that oil gland origin type. So I'm thinking if it is something bad, it's probably a sebaceous cell. And that's why I took pictures, because it just looked a little angrier than something benign like a chalazion should at this point. And in fact, it was a sebaceous cell. And she had, we did map biopsies of her entire palpebral and bulbar conj, no extension elsewhere. She had, we have head and neck oncologists that, it's a very big relief. I don't have to do too much thinking because of the setting in which I practice, where we have a specialized head and neck oncologist. So I'm not debating, oh, should I do a scan to look at her lymph nodes? I just send her to the oncologist and they go gung-ho. And she gets a full body, scan, and she has no involvement elsewhere, and she's gonna get serial imaging because, as you know, sebaceous cell can be a very bad player. But she's doing very well so far. So here we have another example of a patient who, was being treated as just chronic styes, and you can kind of understand why. It kind of looks like two bad styes next to each other. She had been injected with steroid a few times. But again, the history is now starting to seem concerning. It's been going on for a few months. It's not responding to the standard treatments. And this one's a little more diffuse looking, and she has some lash loss. Our other patient, I don't think even had lash loss. This was biopsied and also came back as a sebaceous cell. So if your blepharitis, if your styes are not acting like styes, keep a low threshold to biopsy. Sometimes they even come to you biopsied because just the area that was biopsied showed inflammation. Or maybe it wasn't a pathologist like Dr. Breyer, who's very experienced at looking at these specimens. So you might want to talk to the pathologist. Do you have a colleague who specializes in eye pathology that you could run this by? If your clinical suspicion is high, really pursue it. So this is a lady who came, this is my foray into ptosis isn't, which I thought was very clever. So sometimes ptosis is one of the most common things I see, but ptosis isn't always ptosis. And so I always talk to our residents about looking for the same things every time. That way, even if you don't, 98% of the time, you're doing things that are going to turn out normal, because most ptosis is aponeurotic, age-related ptosis. You don't lose anything by taking that extra time to do these few steps so that you don't miss the times that it isn't just a run-of-the-mill ptosis. So this patient was referred for a droopy lid, which she had noticed, but when looking at her motility, so I always look at pupils and motility, you can see on down gaze, her non-ptotic eye actually appears to retract back. So this is a kind of a classic example of the pathologic eye is actually the normal eye, and her other eye is actually the one that is abnormal. It's, for some reason, it's retracted. It's fibrotic, so some process is going on. So now we can pursue that differential of, well, what are things that might cause that? Thyroid would be the most common one. And she underwent workup for a thyroid. She had some lightly positive Hashimoto's antibodies, but she's euthyroid, so she's going to follow with a endocrinologist, to see if at some point she becomes hypo, and she's just elected not to pursue lid surgery at the moment. But the important thing is to, not just jump to a surgical solution for a non-surgical problem. So chronic conjunctivitis is something that, kind of bridges oculoplastics, anterior segment, comprehensive, everything really. So it's something that I see on occasion, and recognizing some common etiologies of chronic conjunctivitis and what they look like is helpful. So lymphoma with that pinkish appearance that sort of is thicker towards the fornices and becomes more orangey as it gets onto that bulbar conjunctiva. Biopsied one of these, I think that's what it's going to be at the VA just yesterday, although I saw that very interesting poster right there about solitary fibrous tumor, which is another cause of subconjunctival salmon patchy looking lesions, but far less common. So I'll keep that on my differential for that patient. Chlamydia. So anytime I see someone with what looks like sort of an adult with a moderate conjunctivitis that they're saying has been going on for months and is not resolved, I'll put them on some azithromycin. It's 1 gram one time, and often it gets rid of it, especially if you see bulbar follicles. Where I trained at Baylor, the chairman for decades was Dan Jones, who's big in cornea, and he would always, chlamydia was like his favorite, and he'd say, if you see a bulbar follicle, just treat it as chlamydia. I should, but I don't ask too much history. I'm just like, here, take this azithromycin. It's good for you. Amyloidosis has this kind of orange placoid appearance, not always, but that's a typical appearance, kind of a thicker plaque than lymphoma. And xanthogranuloma has that sort of fatty appearance. And for a lot of these conditions, certainly all of them actually, it's important to remember that they're not just ocular conditions, they are part of a systemic process and require systemic management. So blepharitis, anyone who's in oculoplastics, you see a lot of blepharitis. I always tell residents, you have to like the most mundane thing in that field if you want to go into it. So if you're going to go into retina, you have to like flashes and floaters. If you go into oculoplastics, you have to like counseling patients on blepharitis, and I do. I mean, it's irritating. It's it's chronic, and I like having that blepharitis conversation with patients about how you manage this chronically and how it's not going to go away, but there are a lot of things we can do to kind of keep it under control and manage it. But I get sent a lot of blepharitis that's not really blepharitis either. So here are some examples. So this is a more classic blepharitis with the scurf and probably some meibomian gland dysfunction if you look at the slit lamp. This is dermatitis. So I see a lot of dermatitis, and I often see dermatitis caused by blepharitis treatment. So dermatitis looks different. Dermatitis is the skin. Blepharitis is the lid margin. If it's the skin that's red and inflamed, particularly the medial skin, which is thinner, and it's scaly and leathery and has white flakes on it, that's a skin issue. That's dermatitis. And sometimes it's been diagnosed as a blepharitis, and they've been told to do warm compresses. That makes the skin worse. You're breaking down that skin barrier even more. The dermatitis is getting worse. The patient is thinking, maybe I need to do more warm compresses. So by the time this whole thing has cycled, they show up with florid dermatitis. And the first thing is just stop everything you're doing for the blepharitis. Stop the warm compresses, stop the lid scrubs, stop breaking down the skin barrier. Give the skin a break and let it heal. Dermatitis sometimes is a result of contact or allergens and might require patch testing, referral to derm, and kind of a whole evaluation along those lines. Secondary blepharitis, so there's, the blepharitis due to meibomian gland dysfunction and everything, but this, for example, is blepharo, and this probably patient, if they open their eyes, probably also has blepharoconjunctivitis due to herpes rash. So look at the whole face. So the first thing I tell everyone when they're starting their residency is, I'm going to tell you this now, and you're going to think, oh, I'm never going to forget it. But then 2 years from now, I'm going to be turning the lights on for you. Is turn the lights on for the oculoplastics exam, because you get so used to, as an ophthalmologist, working in the dark, that when my colleagues call me in, oh, can you look at this patient? I walk in, I'm like, how can I possibly look at them? I'm like feeling my way around in the dark here, and the first thing is like, can I just turn on this light so I can actually see? So turn the light on. The oculoplastics exam starts with the lights on. When you walk into the patient, you're looking at their whole body, you're looking at their scalp, you're looking at their face, you're looking at their facial asymmetry, you're looking for rashes. That is all part of the oculoplastics exam. So a patient with a red eye, unilateral, maybe with a little skin changes, you should be searching their scalp for lesions. Don't be afraid to get in there. This is a patient with a placoid rash, and I see this sometimes too, being treated as blepharitis. It's on the lid margin. This is actually a rheumatologic rash of lupus. And this needs to be treated quickly, systemically, because what's going to happen is this is going to inflame, then start to scar, contract, and we're going to have a very difficult to manage lid retraction if this inflammation is not treated with systemic immunomodulators. So emphasizing to the patient that we need to get on this, you need to see someone pronto, and we need to calm this inflammation down, is really, really an important part of the counseling with something like this. So pretty much what we talked about. How do you catch the masqueraders? Have a systematic approach, do the same things every time, turn on the lights. Less so now, but even now, we are in a center where we see patients who are immunocompromised, who for various reasons are wearing masks to keep themselves safe. I always ask the patient, can I take your mask off to look at your face briefly? So I always look at their whole face. This is a patient referred for ptosis, and certainly looks like he has a ptosis of one side. But when I take his mask off, I notice he's got an uplift of his lip. He's actually spasming. He's got a hemifacial spasm, and that's why it appears he has ptosis. And then when he's not spasming, he looks like this. So this is a new diagnosis of hemifacial spasm. We do a scan of the path of cranial nerve 7 to look for lesions, tumors, and if not, treat it with botulinum toxin. Do we have time to talk about imaging, or we can pause here and just do questions?
Maybe we should just do questions.
Yeah, let's do questions. It's a good stopping point. Yes.
Hello. So when you send off all your, each one of your chalazion biopsies, are you sending them off in formalin or oil red O?
I send them in formalin. So I actually asked Dr. Breyer about this once. Like, should we be, he said that with, or at least in a setting with an experienced pathologist who's used to looking at ophthalmic specimens, they still have ways of determining like sebaceous oil gland tumors, even if you send it in formalin. So I send it routinely, but I did check before I started to submit my specimens. I checked with my pathologist, who also happens to be in my department, so I would advise you to do so, to check with your department. That's a really good question.